continues to remain so at discontinuation of ECMO also, then the survival gets even more bleak. In pediatrics, same results. Non-survivors had a higher positive fluid overload. So fluid overload is very bad, and one has to, at all cost, try to avoid this positive fluid overload for good outcomes. Now, what about kidney injury on ECMO? So in pediatrics, we use the P-rifle and Kiddigo criteria. And if you are on a grade higher stage of AKI, then obviously your survival on ECMO also is abysmal. Now, other indications for dialysis on ECMO could be poisonings, liver dysfunction, could be bad sepsis, shock, etc. So you're high lactate. So you may need also some form of therapy to support your metabolic derangements and acidosis, apart from your ECMO for your heart and lungs. Now, cytokine removal. We all know that dialysis CRRT, because of convection, it removes your middle molecules. So cytokines can be removed. So also when you have sick patients on ECMO, your CRRT will help remove cytokines. In COVID, this is one study that showed that ECMO CRRT in COVID helped patients. And in neonates, early CRRT actually helps in giving more volumes, so improving volumes for parenteral nutrition. Because you have to remember, neonates, your maintenance fluid volume is very, very less. And if they're on blood products, they would get positive very, very fast. So in pediatrics and neonates, in fact, it makes sense to initiate the CRRT much earlier. And the COVID virus does not spread through the membrane oxygenator or effluent dialysis fluid. Just thought it would interest, because COVID virus is anyway here to stay. So what are the factors affecting survival on ECMO? So the time to CRRT initiation. So new studies have shown that there's really no cutoff time. One has to individualize. But before, multi-organ dysfunction, before the danger of fluid overload sets in. And of course, renal AKI, progression of AKI also impairs outcome, and fluid balance, very important. So for those who don't know, I'm sure you all know, but generally how we calculate fluid overload, your intake minus output by your at weight times your 100. So have to individualize the timing of CRRT initiation in a patient on ECMO and not as preemptive. Outcome, what is the long-term and short-term outcome for patients who develop acute kidney injury on ECMO? Pediatrics, very good survival, good recovery of renal function. However, it's not so in adults. In adults, especially if they have receiving CRRT for more than 7 days or they have other comorbidities, then there is a risk of readmission or end-stage renal disease. So the key now is to avoid fluid overload at all costs. So first thing, calculate, obsessively the intake output. There should not be this knee-jerk fluid bolus response to chattering. One has to address the etiology, because we know when there is hypoxemia, we increase the flows. But what happens when you keep giving fluid bolus, every fellow gives it in each shift, then all this fluid sits in the lungs, and it defeats the very purpose of ECMO, which is correcting hypoxemia, because your fluid itself is going to worsen your hypoxemia. So additional cannulae may be needed, especially in pediatrics, because the flows are inadequate. You have to check the cannulae position. So fluid, before giving fluid to your ECMO patient, really think 3 times whether that patient has earned it before you give the fluid. So be mindful of dilution volumes in medications, antibiotics, especially in pediatrics, and use diuretic infusion and see the response if the patient is not in shock. So you can see this was a child recently for meconium aspiration syndrome. We put on ECMO, and you can see this was on day 0 ECMO. Look at the subcute. And then the subcute on day 2, it's already, there is capillary leak, there is some inflammation, systemic inflammation on ECMO, but this is too much. There's so much of fluid overload, right? And then we had to initiate CRRT, and all that is shrunk. And the lungs also cleared. So we all know that a lot of fluid is actually sitting in the lungs, and then you cannot wean off your ECMO. So how to institute? Now we know the indications for dialysis, renal replacement therapy on ECMO. So how to institute dialysis? One is you can use a separate vascular access, which we all are familiar and comfortable, put up a separate vas cath, and there's no interference with the ECMO. So you have your renal team, and then you have your perfusionist the other side. but there is a access site limitation. How many veins and vessels do we have? There's risk of bleeding because the patient is already anticoagulated. So inline technique is obviously more logical, more everybody uses this, and you use the ECMO pump force to force the blood to the filter. But everything has a little bit of, downside, things that we have to be mindful about. What are they? Air entrainment, hemolysis, a little more complexity, contamination, and maybe increased heparin requirements. Now, if you want to remove only fluid, there's no problem, though no metabolic derangements, etc., or AKI, then just putting a filter would be good enough. Or if you want to remove your solutes and cytokines, then you have to use your CRRT machine. So now we talk about this hemo filter. It's a lot cheaper, but it removes only fluids. It's not for uremia. Now we are going to talk about connections only within the CRRT dialysis connections in the ECMO circuit. So SCUF, that is the inline filter. It is simple, it is easy to set up, low cost, no anticoagulation separately needed. And you can connect it to the ECMO circuit, very small priming volumes. And it can pull a large volume of fluid very fast. But because of the high flows, the filter longevity is not too long. So maybe 4 to 6 hours, and you can take a lot of fluids, ultrafiltrate. It's not very, you can control it with an infusion pump, but you can't measure the ultrafiltrate precisely as compared to a CRRT machine. And your solutes won't be removed, so not your potassium, not your urea, but you can remove a lot of fluid. So good for volume overload or removal of certain drugs. There's no pressure monitoring, so the filters can rupture. There can be hemolysis because of turbulence. So these are the disadvantages, but it's very cost effective for removing fluids when your diuretics are not working. But if there are a lot of other things that you have to address, then you have to connect the CRRT machine. Now, what if we do a separate, so you have the ECMO and you don't want to disturb the ECMO circuit, you put a separate vas cath and connect the CRRT. So what are the downsides? You need more vascular access. There's risk of bleeding, risk of hemolysis. There's large artificial surfaces, so separate circuits, and there can be platelet activation. Plus, the extracorporeal volume is so much more, especially in smaller children, which could interfere with your ECMO flows because it's draining from 2 different sides. So now what we do in pediatrics, what adults do generally is the CRRT and ECMO in series. So in the ECMO circuit, remember ECMO has very high flows while the CRRT flows are only about 1/10, and ECMO circuit pressures are much higher. So actually not too difficult for the flows to go to your CRRT filter. So this is a lot safer, connecting the CRRT into the ECMO circuit, and there are a lot of newer ports for easy connection. Your perfusionist will be aware. It's very controlled. The oxygenator acts as an air bubble, so it can trap clots also. What are the disadvantages? Your perfusionist has to know where to set up, and it's more expensive, especially the replacement fluid, dialysis fluid. So there can be more clotting, and we have always encountered more hemolysis when we connect the CRRT machine to the ECMO circuit because there's more turbulence, 2 filters, and the high pressures in the CRRT machines can result in alarms. So this is a survey done to what mode was employed on ECMO. So you can see SCUF, maximum, and then you have your CVVH, CVVHD, CVVHDF. Now, does it matter or are these just terminologies? When we say CVVH, it is convective. So your middle molecules, cytokines are removed better. That is convective clearance. You can see above here, your CVVH. So your molecular weight in Daltons are higher. When we say CVVHD, it's only dialysis. So it's diffusive clearance of your solutes. So only small molecules are removed. So CVVHDF has both dialysis as well as convective clearance. So that will remove both your small molecules as well as your middle molecules and cytokines. So generally, as per the survey, you can see CVVH was more employed than your and CVVHDF more than your CVVHD, which is only dialysis and small molecules. Now, a cheaper alternative is SLED. So we also call it the prolonged intermittent renal replacement therapy. So it's sustained low efficiency. So same like an IHT, but it's used for a longer period of time. So there's less hemodynamic instability. You can remove good fluid and also low molecular weight solutes. And cost is obviously lower than CRRT because you can use your RO water. You don't need your replacement in dialysis fluid. Now, if we were to connect the CRRT into the ECMO circuit, where should we connect and why? So remember, from the patient to the pump are all negative pressures. So it's minus 200 to minus 100. So it's only negative. And positive pressure from the pump onwards back to the patient. So 150 to 350. So this is very important. You have to remember. So this side is negative and the other side is post-pump is positive. So where to connect the CRRT? Access can be anywhere. But return should never be post-oxygenator because there's the risk of air embolism. There's risk of clot going directly to the patient. But an access from high pressure ECMO circuit to CRRT is a lot more easier. Never return post-oxygenator, as I already mentioned. You don't need separate anticoagulation if patient is, obviously patient is on heparin on ECMO. And warmer, the ECMO warmer itself will keep the patient warm. Usually when we connect patients to CRRT, especially pediatrics, there's a lot of blood extracorporeal, so they get hypothermic, which is taken care of anyway by the ECMO warmer. Ensure CRRT connections are handled by perfusionist only so that there's no air or clot. In centrifugal pump, it is a better as per the guidelines to connect it post-pump, not in the negative side because of air getting sucked in centrifugal pumps, which is what we all use. So managing pressure differences, as I said, there's no single guideline to where we should connect. The perfusionist should be aware of the pros and cons of each connection, and there can be alarms. When you connect it to the low pressure negative side, there's low pressure alarm. When it is to the positive side of the ECMO circuit, then there's high pressure alarm, which have to be sorted out. So what are the different connections? So access to the CRRT can be post-oxygenator. That means the pressure is positive, and return is pre-oxygenator. As I said, you should never return it post-oxygenator. Access can be post-oxygenator and return pre-pump to the negative side. This is what our center uses. So it helps the filter longevity. So it's easy to pull the pressure with the ECMO pressure head. It's easy for the CRRT machine to pull in fluid and return it to the negative side, so there is less pressure on the filter. So negative return to the pre-pump. Access can be post-pump, which is positive, and return pre-pump to the negative side. Access can be post-pump, which is again positive, and return to the pre-oxygenator. So somewhere between the oxygenator and the pump. Then access can be pre-pump and return post-pump. So that's from the negative, but there is risk of air being sucked in, especially when you're too negative. So when your venous lines, when you're not, there are some monitors which do monitor the P1 pressure, that is your pump pressure. And if that is very negative, then you can have more air getting entrapped into your CRRT also. And then return can be pre-pump. So this is another where access also pre-pump and return also pre-pump. So this is a shot that I have taken from the CRRT machine with our regular pressures. And you can see the CRRT machine connected to the ECMO. Look at the pressures that are generated. The filter pressure is 292 here. Return pressure is much higher. So everything is a lot more amplified here. That's why the filter tends to pack up a lot faster when you put CRRT on the ECMO circuit. That's something that we do expect despite the anticoagulation. Hemolysis is also should be expected. Clotting, one has to be very, very careful, ensure that that we don't have big clots. So may have to increase your heparinization. Recirculation, some oxygenated blood comes back, especially, if you're post-oxygenated to the pre-pump, but that is negligible. Filter failure, if there is connected to high pressure. So one has to monitor the pressures also in the ECMO, as well pre and post membrane, as well as in the CRRT, and keep filtration fraction low to avoid filter clotting. So this was a child, the same child that I mentioned. You can see the child is almost disappear on the large bed. This is a neonatal, day 4 for meconium aspiration in our center. And this is the VA ECMO. And the child is already connected to the CRRT, which is into the ECMO circuit. So one thing that we noticed when we connected our pediatric patients to the CRRT on ECMO was hemolysis. And this is very interesting. The carboxyhemoglobin would rise up. You can see 4.8. And interestingly, there's another study now, not an ECMO patient, but an adult intensive care. So carboxyhemoglobin, a reliable diagnosis biomarker for hemolysis in intensive care unit. So that's something for those who don't have plasma hemoglobin and all. And this rises much earlier than your LDH. So it's something we can look in our co-oximeter to see whether carboxyhemoglobin rises, which is an indicator for hemolysis, because as your red cells are destroyed, you have whatever that complex thing, there is release of your carboxyhemoglobin. And when there is hemolysis, you can have low anti-10A, and also hemolysis can worsen your ARF. So actually the reason why you are on CRRT could, be a little more, could have one more reason if there is hemolysis because of your free hemoglobin. Connecting rather than a separate VASCAT for CRRT, putting the CRRT machine in the ECMO makes proning also easier. This was a child with CRRT and ECMO circuit, and proned. One has to be watchful about all the connections because there's risk of infection and your handling. And because the temperature is maintained by the ECMO, warmer, it's hard to, temperatures can be misleading. So you have to go by low platelet count, feed intolerance, especially in pediatrics, tachycardia, etc., for monitoring for sepsis. So drug dosing for antibiotics, especially, give the full loading dose. We know many drugs are sequestered in ECMO, and there is no real data guidelines on all the antibiotics that we use and what are their effect on ECMO. So it's better, we want to save the life. The kidney we can take care of. So give full loading dose and good dose on ECMO and CRRT. You have two machines, you have a lot more circuitry, lot more of the blood of the patient is extracorporeal and less compared to what is circulating in the body. So give full dosing. This is a new paper that I saw which stated that there are a lot of research now going on for creating an oxygenator with a CRRT membrane. So you can see this is the PMP, and this also will hemofiltration. So this is very interesting. So which means you would not need a separate CRRT. One could just use this modified ILA lung assist device, which will serve as both an oxygenator as well as a CRRT filter. That would be very interesting and convenient for everybody. So to sum up, key messages: avoid fluid overload on ECMO because that itself, affects your outcomes. Institute renal replacement therapy early, whatever, be it plain scuff or you're using your CVVH, CVHDF, because any delay can prove costly. Thank you so much. These are the references, and they're quite complete, so it's part of my talk. Should I go to the next talk, Dr. Pranay? Yeah, I think I'm supposed to.
Yes, madam, you continue.
Yeah, sure. So we are now going to talk about pediatric respiratory ECMO. Am I audible?
Yes, madam.
Yes, thank you. So I'm just going to talk about pediatric respiratory ECMO. I'm a pediatric intensivist. And to be honest, though, I know there are more adults and delegates. ECMO is one resource, unlike many other technologies, which actually started in neonates with successful outcome, and then to pediatrics, and then adults adopted this technology.